Thank you very much for joining us this morning into this afternoon for our webinar on tracheostomy management in complex neurodisability. My name is Amy Endicott. I'm one of the speech and language therapists here at the Royal Hospital for Neurodisability, and I work across the Level 1 brain injury service and the long-term ventilation unit.
And I'm Linda Vardy. I'm one of the physiotherapists on the ventilation unit, and I also help support Tracheostomy Clinic.
Fab. So we are recording this webinar today. So we hope that you can stay with us throughout the course of it. But if you have to drop off for any other reasons, we know it's a busy time of day, you'll always be able to access it later on the Royal Hospital for Neurodisability YouTube page. And just to be clear, although we both work with ventilated patients, the webinar today will be focused around patients that are not ventilated. Okay.
So today, what we will be doing is just doing an introduction to how we think about trachees and our management of them during a weaning process and the complexities around this. We're obviously not going to have time to cover all the themes and topics included in detail, but we will try and make sure that we do a brief background to and indications for tracheostomy, complexities that surround the tracheostomy population, management, in this population, the practical considerations regarding weaning and long-term management, and then have some time at the end for some questions and reflections.
Okay, so this is a picture here of our lovely hospital down here in Putney, if anyone's been down here. And we have a range of services that we offer. So we have a brain injury service, which compiles of 2 Level 1A neuro units, and that includes rehabilitation, but also assessment and management of prolonged disorder of consciousness and disability management. We have a neurobehavioral unit. We have a ventilator unit for people that come for short-term optimization, or they may stay and live here the rest of their lives. And we also have specialist nursing home where we take patients with a range of complex neurodisability. And our tracheostomy beds are spread out across these services, of course, predominantly in our ventilator unit and on the brain injury service, but also there's quite a lot on the specialist nursing home as well. Okay, so to start with, we're going to set a poll up. I think Anna is on the other line and she will put the polls in the poll function. Yeah, so we've got a range of questions. So the first one is, what is your role? Okay, great. So we've got mostly speech and language therapists, some physiotherapists, nurse, and some other professions as well. Okay, fab. Let's move on to the next question. How many years experience do you have with tracheostomies?
Oh, it's looking pretty equal.
Okay, great. So we've got a really good kind of mix of people there in terms of your experience levels. Next question is, do you routinely complete tracheostomy weaning as part of your role? Great. So again, about 50-50. So we'll hopefully we'll manage to cater for both sides of these kind of experience levels. Sorry, bear with me. So next question, what sort of area do you work in? Wonderful, thank you. And then the final question is, do you work solely with patients with neurological conditions? Mm. Lovely, thank you. It's really good to get to know a little bit about the people that are listening to this presentation. We move on with the slides.
Okay, fab. So just a bit of a refresher because we've got a bit of a mixed kind of audience here. So thinking about tracheostomy basics. So if we look in the top left corner of the screen, we can see the tracheostomy, which is a tube, an artificial airway that is placed directly into the trachea. Typically sits between the second and third tracheal ring. Important to note when you look at the profile of the anatomy here, it sits below the larynx and the vocal cords, which is the valve that we use to manage airflow and in turn creates the pressure that we need for voice and to close our airway when we're swallowing and to help us with our cough. In the X-ray image towards the middle, you can see, and this is a still from a video fluoroscopy, which is an X-ray assessment of swallowing that speech and language therapists use. And you can see where the tracheostomy is sitting in the airway. So you can see that it's sat in this kind of light, bright white area, which shows that there's an airflow. So it sits in the trachea. And then behind that, you can see a thin, dark line, which is where this person's swallowing food or drink and it's going down towards the stomach. So you can see how close here the trachea and the stomach and the opening to the stomach, the esophagus are. Then if we look at the tracheostomy tubes, if we look at the picture on the far right, this is an image of a tracheostomy tube. So we can see that it's made of a kind of hard plastic. The thing to note for today is that we can see the balloon kind of circumferentially around towards the end of the tube. So this is what we call the balloon or the cuff. And then the blue wire is the pilot balloon, which is what we use to put air in or to take air out of that cuff. Okay. And that cuff sits with that tracheostomy directly into the airway. And then the final image is the endoscopic view of the larynx and the vocal cords. So we can see the vocal cords, they open and close gently on respiration and they close and vibrate on speech. And when we swallow, all these muscles close and squeeze tightly together. So we're seeing where the tracheostomy sits. As we said, the important thing to think about today is the airflow. So that tracheostomy with that cuff, when it's in situ and that balloon is up, this changes the airflow. So when the cuff is up, the air just comes in and out of the tracheostomy only, as the cuff provides a kind of physical block. It separates the upper and lower respiratory tract. Whereas when the cuff is down, the air can go in and out of the tracheostomy tube and the nose and mouth. Okay. Fine, let's go to the next.
So the reason that we're obviously interested in trachees is there's quite a lot of them. Between 15,000 to 20,000 tracheostomies are carried out each year in the UK, and a lot of those patients will continue to have tracheostomies for an ongoing period of time and will require our expertise to help wean them. So tracheostomies are performed in many brain injured patients, but it's difficult to get an exact number. Most research suggests that it can be anywhere from 46% upwards to 70% of brain injured patients who are going to require a tracheostomy. The majority of these are going to be performed percutaneously rather than surgically. So they'll be done at bedside, and normally around 90% of them are percutaneous. The rate of tracheostomy insertion is higher in neuro ICUs than it is in a general ICU. Again, supporting that idea that quite a few of our brain injured patients or other complex neurodisability patients are likely to have tracheostomies. The number of patients we currently have at the RHN with tracheostomies over the whole of the services that Amy mentioned earlier is around 76 patients, and that's fairly standard for us each year to have around that sort of number of patients here with us. So the indications for having a tracheostomy in neurodisability predominantly arise due to a failure to wean or a slow wean from invasive ventilation when people are in ITU. And the reason for this is normally secondary to the neurocompromise in these neurodisability patients. Many of them could have low arousal at the beginning of their stay in ITU. They may have more medical instability, high secretion loads, absence of protective airway reflexes, and depending on the site of the injury, they may have lost or have absent completely. Reflexes may just be slightly withdrawn reflexes. They may have impaired respiratory drive, and they will have had a failed laryngeal wean in the acute setting due to dysphagia, and they potentially then will move on to a rehab unit with that trachea still in situ. It's good to kind of be aware that despite the ability to wean off the ventilator, a lot of the neurodisability patients will still have aspects of these difficulties, and so that tracheostomy may stay in longer than the ventilator is required for. Apologies, I've got a bit of a tickly throat, so if I keep stuffing, you have to bear with me. There may also be reasons for putting a tracheostomy in terms of altered airways or an upper airway obstruction, particularly if there's been some trauma related to the neurodisability. Occasionally, surgical support may require tracheostomy to remain in, just so that ongoing surgical interventions can be continued more safely. And there will be a cohort of patients who will require it for long-term ventilation, such as M&D or spinal injuries. But we're not going to cover that today because that is taking this a little bit more into a complex kind of area.
Okay, lovely. So the first thing to think about is the variables in initial tracheostomy management. So there's a range of kind of interrelated variables that contribute to the initial management and weaning success in this complex neuro cohort. So, for example, I'm not going to go through all of them in the interest of time, but mobility, we know that there's a clear relationship between mobility level and chest status. Infection risk, so thinking about, is that patient susceptible to any infections? What has their antibiotic use been so far? Do they have any current infections? What is the impact of having this foreign object directly into the skin? Is that helpful if they've already have other infections? Hypersensitivity. So sensory changes in this neuropopulation are really, really common. And this is across all of the body. So this will affect, we see it commonly affecting limbs, but it's also going to affect someone's airway. So this might affect what we see at bedside with these tracheostomy patients. Fatigue, obvious one, really, really common in this complex neuro cohort. And we know that fatigue has a really clear impact on sensory and motor function and response. And respiratory drive, as Linda touched on before. So actually, dependent on the area of neurological damage, do they have sufficient respiratory drive to maintain the correct respiration pattern that they need? Okay, and that happens outside of patients that are ventilated. But there's three main ones that we need to have kind of in our clinical lens. So swallowability, what's that person's ability to safely manage oral intake? With our trachea patients, we're thinking before that, how are they going to manage their saliva? So we all produce lots of saliva every day. We need to be able to safely swallow that away into our stomach rather than it going towards our lungs. So swallowability. And also, what is the current function and integrity of that swallow musculature and the larynx itself? So those tissues and those cartilages that we use to get a good swallow. Airway protection, so that's someone's ability to detect and respond to something going into the airway that shouldn't be. And then airway patency. And by that, I mean the patency of the upper and lower airways, because this is going to be needed throughout that weaning process to make sure that the person has enough breathable space that they can breathe without this artificial airway. Okay, so have they got enough room in their anatomy really to breathe in and out?
When we come to the point of thinking about whose job is it to look after the tracheostomy wean and to manage that, who are we thinking about? We're actually thinking about a whole MDT approach, and evidence shows that there is a multidisciplinary approach is the best management plan for this. You need skills from every discipline to be able to assess, monitor, and plan the patient's management through this process.
Okay, so coming to these kind of initial variables in tracheostomy management. So the first one, which is a nice and big one, and is probably the most common reason as to why a patient would be admitted to us still with a tracheostomy in situ, is dysphagia. So we know that swallow is a complex process which requires cortical and subcortical input to be effectively executed and modulated. Lots of sensory and motor innovation to the pharynx and larynx to make sure that these good motor patterns result in a safe and effective swallow. And we know this is so common in people with neurodisability. And as we said, they'll come to us because that laryngeal wean has failed in acute, and this will be because they've had an inability to manage their saliva effectively. So the normal swallowing mechanism, if it's not sufficient to prevent saliva going in the airway and materials going into the airway, it's going to cause a risk, especially if it's carrying bacteria in already a high risk patient, okay? So an inflated cuff provides that kind of physical barrier between the pharynx and the trachea, resulting and hopefully reducing the amount of saliva that is going in towards the lungs. So it's to try and reduce aspiration in those initial stages. But I think it's important to think about that it's not just neurology per se that drive dysphagia in this population. So we know that swallow musculature and laryngeal integrity can also be impaired by other factors that cause sensory loss. So things such as trauma from the endotracheal tube itself. At the point of injury, lots of our patients have had to be kind of tubed. A lot of them are tubed on the scene and then ventilated before they get into hospital. So it's about maintaining an airway, not necessarily treating the larynx well. Reflux, really, really common in neuropopulation, trauma and nerve compression from the endotracheal tube and how long that's been there. So, and these sensation changes, as we said, can be kind of hyper, so things like laryngospasm, but also hypo, so downregulation and aspiration. The other thing to think about in terms of dysphagia is the trajectory of the dysphagia. So we know as clinicians that some dysphasias will resolve much quicker over time, and we can make predictions based on neurology and what our clinical assessment is. So I think thinking about the trajectory of dysphagia that you've seen so far with a patient is really important when you think about where to go with your weaning. Medical stability. So dysphagia happens in a context, and this means that it equates to different risk for different people. So risk is a result of the range of factors that the person has. So we know that not everybody that aspirates gets an aspiration pneumonia. We know that people that aspirate that are immobile and have poor oral care and are on lots and lots of medications, they are more likely to get an aspiration pneumonia. Okay, so it's thinking about this clinical context for the patients. And yeah, so, there's lots of things to think about in terms of when we're managing dysphagia and what we want to be kind of keeping our eyes on. It's not just, oh, they've got a really bad swallow. Okay, so I'm going to touch on this really quickly, but we've obviously talked about the sensory and motor patterns, but I think sensory loss in the aerodigestive tract is really, really important when we think about tracheostomy. And when we get sensory loss in the larynx, it's really problematic for our patients. So this sensory input essential for functional swallowing, as well as triggering airway protection, so that laryngeal adductor reflex, clearing our throat, coughing, etc. And we know that the internal superior laryngeal nerve is a laryngeal receptor nerve that helps produce these afferent signals that are necessary for normal swallow, and they provide feedback to these central neurocircuits that help us close and protect our airway. And the paper at the top here demonstrates that really nice, where they used a anesthetic blockade of this nerve in healthy individuals. So this is people with good motor patterns. They didn't have any dysphagia before, and yet the sensory loss really impacted their swallow function. The two other papers here kind of corroborate this as well. So saying that sensory impairments in this musculature can be directly correlated to an increased risk of aspiration and, more importantly, aspiration pneumonia. So we know that sensory impairments, cortical control, can impact and reduce sensory connections in swallowing following neurological impairments. But actually, there's some added things in terms of the process of tracheal intubation and tracheostomy, so local trauma causes, and they also impact sensory function. So then if we add in an inflated cuff, we've got our kind of organic neurological problem, we've got local trauma or things that we've acquired during the acute admission, and then we inflate a cuff, and we're starting to bypass the kind of supraglottis, subglottis, glottis, reducing that airflow. This is further going to compromise the reflex to close our airway off when we swallow, and also impact coughing and clearing the throat. So the literature is really, really clear about this. And although we know that the tracheotube itself is not causal to dysphagia, we need to be aware that the cuff status can exacerbate and really impact our patient's swallow, their coughing and their responses. Okay, so again, just kind of hammering it home, it's a bit tricky. It's quite a lot to unpick in terms of dysphagia with tracheostomy patients. It's sometimes a bit of a headache because there's lots of questions. When should we start? Should we start? But we really need to be aware of this relationship. We need to recognise that keeping a cuff up is not going to help somebody's swallow, and that there's other things that contribute as well. So we need to think about what are the levels of sensory impairments and what can we do about them. You know, is it a down regulation due to a cuff inflation, or is it a pure organic dysphagia due to a brainstem impairment? We also need to think about the fact, not just sensation, but that coughing and swallowing are also pressure generated activities. So disrupting this pressure in this airflow can also cause difficulties with these areas. So we need subglottic pressure, so pressure building below the level of the vocal cords, with these sealed valves at the mouth and at the soft palate, to get enough pressure to help us have an effective swallow, to drive things down from our mouth, through our pharynx and into our stomach. The same way that we need sealed vocal cords and a sealed circuit to build enough intrathoracic pressure to cough. So if we have a trache, we're losing sensation, but we're also losing that pressure system. In terms of thinking about when to start, so it's not always that, you know, if we start at all, it's more where we should be starting weaning, but when are we going to do that? So again, if you've got a patient whose trache is a primary dysphagia and aspiration is what the team are worried about in terms of commencing your weaning, think about what your risk factors for an aspiration pneumonia are. I think historically there's been a potentially kind of risk-averse approach to trache weaning with patients with dysphagia, but use your dysphagia knowledge to educate your team and accept that it's most likely going to be kind of risk mitigation rather than risk elimination.
Okay. So the second kind of consideration that we're looking at is our airway protection. And obviously there is a continuum of airway protective behaviours, and as shown in the diagram above. So it can start with, as Amy's just been mentioning, the swallow and the laryngeal kind of reflexes, but will work all the way down through the airway down to your cough reflex as well. It's important to remember that with individuals with an acquired brain injury or complex neurodisability, that there will be impairments across the range of this continuum. So if we pick apart cough a little bit more, we know that our cough is there to help us remove mucus and any airway obstructions or irritants, so that we're trying to maintain a healthy chest state. Difficulty clearing secretions is quite a predominant factor that can lead to failure in decannulation if we're trying to get rid of a trache. And so making sure that we have the ability to clear our secretions is still very important. As Amy's explained, trache impacts the pressure changes. And so if we have a neurological condition that is impacting our muscle strength and the cough mechanics, so that glottis closure, then we're not going to be able to build up the pressure to be able to generate an effective cough and clear the chest. But we obviously also need our inspiratory and our expiratory muscle strength and the coordination of all of those movements to be able to work together to be able to generate the cough. It has been shown in a few research articles that if you've got a greater peak cough flow when coughing, sorry, apologies, I'm getting myself muddled now, jumped ahead of myself. With the cuff up, the article was looking at how does the cuff impact our peak cough flow. And with the cuff up, it was shown that the cough was significantly weaker than when the cuff was down with a one-way valve in. In fact, once the cuff was deflated and a one-way valve was inserted and you could generate that glottic pressure, the peak cough flow went up 38% greater than it was with the tracheostomy cuff in place. The only person in the study that Kowalowski did in 2017 that had problems with and showed no difference with the peak cough flow was someone who actually subsequently was found to have a subglottic stenosis. And so there was actually additional airway issues that were impacting that. But everybody else within that study showed that difference with the cuff deflation. Our cough is going to be either a stimulus-induced cough or a voluntary cough. And that's something to be aware of with our neurological client group. Some of those reflexes won't be present anymore depending on where the injury is. Any cough, whether it's induced or voluntary, will have some sort of cortical neuroprocess to it as well. So even if we get a stimulus-induced cough and the urge to cough, we can still at times override that with our cognitive kind of centres. So it might be that, for instance, in the middle of a really busy environment when you're trying to make sure that you don't interrupt things, you will try and suppress a cough even if you feel that you need to. However, obviously thinking about our neurological patients, we want to make sure that we aren't just relying on a voluntary cough, but we have some of those stimulus-induced coughs present as well. Current evidence suggests that both voluntary and reflex peak cough airflows are significantly reduced in patients with TBI, and that's relative to normative values. Perrin in 2017 also looked at whether it was better to have a spontaneous cough or a reflex cough, and found that the presence of a spontaneous cough was related to a more favourable decannulation process. So it is worth just keeping an eye on when your patients are demonstrating their ability to clear their secretions, whether it is just through you asking them to cough, or whether it is in response to something penetrating their airway or moving around in their chest and stimulating that inducible cough. Cough reflex can be blunted by excessive saliva. So if you're getting a lot of buildup of saliva in your upper airways in the glottic area, then your body's going to adapt over time, and you will find that the cough reflex does become less responsive. Obviously, there are other things that will have an impact on how our cough can be generated, and our neurological impairment will be impacting other areas of our body, like we've already mentioned, in terms of our respiratory muscles. But over time, if a patient is dysphagic and they're not being able to get as much nutrition, there will be some malnutrition element to it, and obviously making sure that the whole team is involved and that a PEG is inserted or an NG tube is inserted if needed will help to stave off some of those malnutrition episodes where you could end up with more weakness and fatigue in your patients. However, there will be things like tonal changes and postural changes that can increase chest deformity. All of those things are going to lead to less compliance of your chest wall, and so then again altering your cough. Any changes that reduce the amount of air that can be entering into the chest to be able to provide a good lung volume, if that's not possible, then you're going to be starting to get stiffness within the lung itself and starting to get changes in the parenchyma as well. And so you will have less of an effective cough, but also a worse environment for those for clearance of chest secretions.
Okay, so moving on to our next consideration, so airway patency. So we see a range of short-term and long-term complications in the airway that may be related to original injury, neurology, or intubation during acute admission. So we've talked about laryngeal change in sensation that can occur and impact swallow effectiveness, but let's have a think now a bit more about airway patency. So we tend to see two types with our neuro patients, so obstruction or collapse, and we note these throughout the airway. So that's really important, that actually it's not all necessarily things that just happen kind of in the larynx. It can also happen subglottically, so below the glottis, below the vocal cords, and also in the trachea, okay? And the common things we start to see are edema. So edema is obviously really common. It happens as the body's response to kind of trauma and friction, and we also see it a lot in our patients who are tube fed, and if they've been in ITU for a long time, they've been refluxing, the mucosa's changed, so they kind of get edema and swelling. But that can be quite significant to the point that it does become obstructive of airway patency. Granulation, so again, from trauma granulation, if no one's seen it, kind of ends up looking like a little raspberry, really, doesn't it? Where the tissue has been damaged. And again, with the right management, that can disappear and kind of heal quite well. Vocal cord palsy, so of course our vocal cord movement is innervated by our recurrent laryngeal nerve, and so that has cortical control. So from a neurological perspective, that may impact cord opening and closure, but also trauma itself. So typically if it's a neurological etiology, we tend to see a unilateral cord palsy. But if we're seeing bilateral, we're thinking more about postglottic scarring and fixation that again could be caused by trauma, particularly intubation trauma during an acute admission. Bulbar collapse, so that's an interesting one, and I think something we're seeing more and more, particularly people with significant cranial nerve damage and damage to cranial nerve 9. We see lots of dropping in of the lateral pharyngeal walls, and if the person is already not mobile and these tissues are quite large due to their anatomy, that can be very obstructive for their breathing. Laryngotracheal malacia, so again, collapse anywhere throughout the airway, and this is slightly different to bulbar collapse in that bulbar collapse is normally neurologically driven, whereas laryngotracheal malacia is normally driven by the presence of the tracheostomy or the ET tube. Tissue changes, so again, body responds in kind of weird and wonderful ways, a laryngeal web, which is literally like a web of tissue across the larynx. Arytenoid prolapse, so the arytenoids, which are the kind of two little, I don't know what's the best way to describe them really, two little structures that sit at the end of the vocal cords, especially if we have vocal cord damage and the vocal cords become weak or lax or aren't functioning. The arytenoids, which would normally sit rigid towards the posterior of the cords, can start to drop in, okay? And then if you've got swollen arytenoids, you've got edema there, which is a common place to get if you've got reflux, because it will happen in the posterior portion of the larynx. Then that can become really obstructive as well. And post-glottic scarring, as I've already mentioned. I've put here an asterisk next to behavioural compensation, so things like inducible laryngeal obstruction. We see them less, but I think it's important, and we'll come on to it, that obviously when somebody's airway is impaired, the body does try and respond and compensate, and that person might try to. So I think ILO, particularly we're seeing a lot more in our spinal patients, is quite common. So there's kind of start to be kind of behavioural responses, and they can be quite obstructive to the airway and to people's breathing. Okay.
So weaning and when to start weaning, as we've said, it's not very well defined. There isn't particularly any literature that supports one process, and there's no agreement on when you should start, how long it should take, what process you should follow. There's various different ideas around that. So it's a bit of an art, not a science. It's going to be led by your patient's clinical need and reasoning. So it is good to sit down as an MDT and have a think about what is the goals for the patient. Are they at an optimal point to start doing this? Do they have good airflow around the trachea? And what are we trying to achieve ultimately for that patient? So it is important though, because as a team, we'll be thinking about what are the risks of keeping that trachea? And obviously there are multiple risks. You can get irritation from the tube, which can cause excessive coughing, airway inflammation, or some of the airway trauma that Amy's just mentioned within the obstructive type injuries. It's obviously an open stoma site for respiratory potentially infections and skin infections. And so it is, obviously very important that we start thinking about this. So weaning, we've got to think of more as a proactive approach, not reactive. We want to make sure that we're looking at what's best for that patient.
Okay, so weaning, again, as we said, better weaning is better outcomes. And the literature says that. And by better outcomes, we mean, everything really, kind of reduced lengths of stay in hospital, better swallowing outcomes, communication outcomes, physical outcomes as well. So the earlier that we can get in and wean, the better. However, we do need to be really considerate when we're doing, and weaning is actually a very complex process. I think sometimes it almost gets a bit oversimplified because there are lots of things to think about. As Linda said, be proactive, not reactive. So rather than this, we're just going to wait for their secretions to go down and then we can do it. That's fine. But what are we doing in that interim to maintain other function that they have in their larynx, in their airway? And what are we doing to kind of get those secretions down rather than just waiting for things to happen? Again, a risk assessment is really important. So risk is different for everybody. And a good example of that is aspiration versus aspiration pneumonia. Lots of people aspirate. Not everybody gets an aspiration pneumonia. Only a small percentage get pneumonia from it. So thinking about what is the individual risk for that person. Normalization is always good. So once you start to normalize airflow, you have a better impact on oral health, your gustatory function, etc. But you do also need to think about your timing. So readiness for weaning, and by that I mean, if a person is in a rehabilitation block and they are making progress in some areas and you think actually, okay, weaning is a bit risky, when is the right time to start that during their admission? And what are the conversations you need to have with them about that? Okay, so the first thing we're going to touch on is laryngopharyngeal reflux and gastroesophageal reflux. So how would we approach that? So we use a variety of PPIs or sodium alginates or steroids in response to, I suppose, initially to try and kind of keep reflux at bay, and then steroids in a more reactive approach if we notice that there's edema on our scopes when we're looking into people's airways. PPIs obviously and sodium alginates work slightly differently. I'm not going to go into that now, but I would say that the evidence base is very much towards sodium alginates for keeping down volume reflux. And we know this volume reflux is what we see more in our patients with brain injury. And we see this because they have issues with gastroparesis and poor gastric emptying. So this material stays in the stomach due to this cortical control that's needed for gut movement. Again, if people are with severe brain injury, they're being peg fed and they're immobile, this also heightens the risk of the volume reflux. And the fact that they're regurgitating feed. So feed is very concentrated. So this is a lot more damaging than refluxing, food or water kind of standardly that's been broken down in the gut. So yeah, we're thinking about medications. We also can think about their feeding regime and their routine. What's the rate that we're feeding them, or what time of day are we feeding them? What position are they in at bedtime? And of course, the positioning for this. So keeping them upright as much as possible during their feeding and afterwards as well. And I think this sounds very obvious, but how much it actually happens practically, I think is up for debate, because yeah, it should be happening, but it isn't always happening. And it can have a huge impact, especially in patients that can't tell us that they're experiencing reflux, which is the cohort we're dealing with here. These are people that can't really self-report. So we need to be kind of thinking about all the contributors. The next thing is secretion management. So there's lots of talk always on secretions, but I think it's really important to think, okay, where are they actually coming from? So use your clinical reasoning. Are they primary, just oropharyngeal from dysphagia, or are they primary pulmonary from an issue with lung health, premorbid chest problems, poor mucociliary escalator function, or is it oropharyngeal secretions becoming pulmonary because of aspiration? So there are many drivers of secretions. Dysphagia, reflux, lack of humidification is a really big one that we also need to be thinking about. And of course, bacterial, fungal, and viral chest infections. So we want to try and reduce this load. And in terms of dysphagia, yes, it's important to reduce the load because we want to reduce what's going into their airway. But as Linda touched on, actually, it's just not about reducing the risk of aspiration, because reducing of saliva is not going to suddenly fix their swallow anyway. But reducing saliva does improve the laryngeal environment, which may optimize swallowing. So we know that high saliva in the oropharynx and the larynx can have a desensitizing effect due to the kind of habituation of secretions being there. And we see that a lot in our patients, that they've just become flooded and they've just now got used to it and now they don't respond at all. And actually, as soon as you start to manage things a bit better, these responses do come back. So we're trying to kind of work on that sensory dampening. And also, obviously, high saliva load can impact airway patency because it results in edema. When you've got lots of secretions that are sat around the piriforms and lateral channels and everything just gets a bit fluffy and swollen. We can always kind of, attribute a lot of that down to secretion kind of holding. So we think about medication, treatment, or behavioural management. Behavioural management might be things like swallow reminders, head positioning, and also even if we can get that person just having small sips of water to try and clear things through, that's really helpful. A big thing with secretion management is documentation. So again, think about what you're assessing and hypothesizing. There's no point doing an observational drooling scale for someone that you think is losing posterior saliva posteriorly. It's not going to capture the information that you need. Other things that we need to make sure that we optimize: oral care. All the speech therapists will know this, and I'm sure a lot of the physios too, because we all bang on about it. Oral care is one of the highest predictors of aspiration pneumonia. So it's a higher predictor than aspiration itself. So the bacteria that grows in a mouth that is warm and wet is really, really harmful. And I think the other thing is just that a dirty mouth, it will preclude swallowing. People aren't going to want to swallow when we see that they don't respond when their mouths are dirty and dry. Positioning, also really, really important. So make sure you work as an MDT to do this. The person that sat there with a hyperextended neck and their airway open, that's not helpful for their swallowing. So sometimes it's just getting those kind of ground level basics in before you get to the next stage.
Just thinking a little bit more in detail about our secretion management, we're going to be looking at our saliva management and our pulmonary secretion management. The pulmonary secretion management we'll come on to in a little bit more detail on the next slide. In terms of our saliva management, it's obviously required partly because of our dysphagia that Amy's just talked about. But we're also just thinking about trying to manage that in various different ways. That may be medically related, or it could be through our kind of swallow rehab kind of interventions. Okay, so from a medical point of view, there's lots of guidelines and articles to help support us. Some of them are just here on the slide. They talk through the various different medications that are available and how we might use those within a neurological population. We're going to be thinking about our anticholinergics, so something like our glycopyrronium or hyoscine patches, which will start to inhibit the action of neurotransmitter acetylcholine, and that's going to help reduce our secretion burden. But the thing to remember is that that's also going to have an impact on any smooth muscle within the body. So it could be our gut, our bladder, our eyes. And so when we're thinking about our medication, we do need to consider the effect on other organs within the body and whether that potentially is going to cause more problems such as constipation or people complaining about dry eyes and feeling uncomfortable. The other thing to be aware of with our anticholinergics is the neurological burden from them, because some of them do cross the blood-brain barrier, more likely to be something like hyoscine, and that can impact on drowsiness of our neurological patients. Considering when you start those medications or which medication you use will come into play, kind of thinking about what your aim for that patient is. If you're currently assessing their level of alertness, you may not want something that's going to cross the blood-brain barrier because you're not going to want to diminish any of those alertness responses that you're looking for. The other option that you've got is to look at a more focal intervention, such as Botox to the saliva glands. And that can be, in a lot of patients, something that is less kind of have less side effects, and so help them with their management without causing some of the other kind of issues that come alongside it. In terms of our pulmonary secretion management, obviously this is required because we've got more immobile patients generally when we've got our neurodisability population. Often with a tracheostomy, and as Amy's kind of alluded to as well, there's reduced humidification. If you think about the cuff being up on the tracheostomy, you're not getting all of our normal humidification through our nose and mouth. And so you could potentially end up with much more drier airways, and then secretions that are going to be getting thicker and mucociliary escalator not working as well as it should be. So sodium chloride nebulizers may be your first line, just to get things a little bit more loose and easy to move, and considering whether you need some sort of heated humidification or another humidification device like a HME, and making sure that those are used routinely. If things are becoming more difficult and not clearing so well, you've got options of working up. We tend to have a step ladder here of things that we'll use, so we might move from sodium chloride up to hypertonic saline to help clear those secretions. If they're still being very difficult to clear and you've got very tenacious, thick secretions, we might move on to something like NAC-NEB, so N-acetylcysteine. They work in slightly different ways just to break down the secretions, and then hopefully that will help with clearance of those secretions from your chest. The other option is also to think about using something more systemic like carbocysteine, which will also help the viscosity of your secretions. The difficulty with working with our saliva and our chest secretions, though, is that you have to get a balance. So if you're thinking that we're trying to dry up saliva to get rid of that saliva burden, that will also be having an impact on your chest secretions. And so getting that balance right and making sure that we're not adding in so many anticholinergics that we're then having to add in a huge amount of mucolytics is quite difficult. And we do have to keep an eye on both of those things and try and work out where can we get that balance right so that we're not impacting another system within the body.
Okay, so the next thing to think about is airflow. So we know that airflow is important for the mucosal receptor field and supports the sensation, which is going to do those nice or kind of natural protective responses. So weaning, so getting the cuff down, is rehab in its own right. So I think we need to, as we said, give it the time and attention that it needs, really. So we put here, obviously, cuff deflation is the best way to gain airflow. That's very obvious, and kind of incremental kind of increase of that throughout the day, as is based on your clinical assessment. We're not going to give you today, I think as we said at the beginning, kind of there's no kind of flowchart or process on how to wean a patient. It's all about clinical reasoning and kind of understanding and appreciating all the factors that could contribute. So for some patients, if they come to you and they're cuff up all the time, but your assessment's shown that they've only really got an airway issue, then you can drop that cuff all day, no problem. But if they're coming to you with some dysphagia and you're thinking, okay, this, and this, then you might wish to do a slower wean with kind of working on those other strands of optimization and rehab as well. So we tend to say one increasing period a day if we can. That's primarily because putting the cuff up and down is an intervention in itself, and we just want to try and reduce that. Always, if you can get a cuff down, you can get a valve on, always get a valve on. The research shows us that obviously having a valve in situ is much better for restoring that subglottic pressure. Build it into the routine. So think about how your cuff down, kind of don't just come along and say, oh yeah, we've decided we want the cuff down for 4 hours today, just do it whenever. Think as your SLT and physio together, okay, how are we going to build it into this person's routine? When's the optimal time to do it, and work alongside your nursing team? As we said, it's rehab in its own right. And it's obviously also got this benefit of kind of voicing and communication as well. So we're talking about it a lot in terms of kind of working towards weaning the trachea, but obviously a huge impact in terms of communication also. So a little bit here on one-way valves. So a one-way valve works by being placed on the end of the tracheostomy. So the image here is a Passimura valve, the top green one. Lots of different types of valves kind of available. A lot of the time it's just dependent on your kind of local policy and what your procurement is of the valve that you use. Unless you're working with ventilated patients, then you do need specific valves to go in line. But essentially that works by the patient breathes in through the trachea, and dependent on the valve, either as the person finishes breathing in or as the person starts to breathe out, there is a little valve literally in this attachment that closes, and that means that all of the expired airflow has to go out through the glottis and the larynx and the nose and the mouth. So it has this kind of no leak design. And this also will help restore voice. So we find sometimes that people don't get a voice with just the cuff down because there's too much leak in that circuit that I was talking about earlier. But actually then with a valve on, their voice is much improved. And there's good evidence that this improves cough and swallowing, and that sensation is then returned, to that laryngeal complex. So this laryngeal adductor reflex is also restored. There's this myth about one-way valves impacting recruitment and making work of breathing more and collapsing lungs. If you're interested in looking at this, Annalisa Sutter's got some really good work that she's done around that, and actually the evidence is that it promotes lung recruitment. So it's really good in terms of helping sensory and motor function, both in the larynx and in the lower respiratory system as well. Okay, so another option, if we can't get the cuff down, obviously getting the cuff down is always preferable. I want to make that really clear. But for some patients, sometimes you just can't get the cuff down, and particularly with ventilated patients, although we're not talking about them, this is something that we would be looking at using. Or people that might not just be tolerating long periods of cuff down for a reason of secretions or hypersensitivity. So you might need something just to bridge that gap to begin with. So this is something here. Now we here at Putney are calling it above cuff airflow. It's also known as above cuff vocalization, but the reason we're calling it above cuff airflow is a similar reason that we call one-way valves and not speaking valves, because for lots of our patients, if we're going to be doing this, the brain injury still precludes them being able to talk and interact anyway. So we've got this above cuff airflow, and the idea is for kind of laryngeal resensitization. So this involves medical air or oxygen being titrated in through the subglottic port, and the subglottic port sits on top of the cuff. And then that results in, as you can see on the picture on the right, the air coming out above the cuff and then being directed up through the vocal cords and up through the pharynx, oropharynx, nasopharynx, in the same way that we would be in typical kind of breathing. So it's trying to mimic the typical route for airflow when we're voicing. It's quite limited in its use. The evidence is a little bit patchy, but I think anecdotally for some patients it is helpful. We're only using it for a really short period of time because of the drying effect of using the oxygen or the medical air, because obviously it doesn't have any humidification. So that's a really big consideration, especially if someone's already got a lot of secretions. It doesn't improve lung recruitment. It doesn't improve subglottic pressure, but it is helpful in these cases where cuff deflation isn't possible. And as I said, it can be a nice bridging tool to cuff deflation and using laryngeal resensitization. I've just directed you quickly to external subglottic airflow. And this is for patients who are dysphagic and have a trachea and have a severe brain injury. So this is the most kind of relevant research to the population we're talking about. And they demonstrated that the impact of using this airflow, increased swallow activity, and the subglottic secretions also reduced. So of course, cuff down is always preferable, but I think it does have its place, and it is something to think about in those early stages for sure. So the last strand that we're going to talk about before we move on, we've titled as kind of rehab. So you've optimized your patient with medications as needed, you've tried to get some airflow going, and now you're thinking, okay, what other things can we do to restore those and optimize, well, not optimize, but restore those functions as much as we can. So thinking about your larynx and how your larynx is behaving. And if you've got patients that can interact and that can engage, think about any kind of behavioral management you can do to get that larynx moving in a kind of more normalized fashion. As I said, we see a lot of this negative compensation, so things like deconstriction, etc. If you can see them under scope and do that sort of thing with them, that's really good. You're not too early to do that. Dysphagia therapy. So of course, if they've got a dysphagia, you need to be treating their dysphagia therapy the same way that you would with a patient that isn't tracheostomized. You may have slightly different considerations, but they still need dysphagia therapy. So thinking about getting that swallow going as much as you can, thinking about sensory treatment, using EMST, which is expiratory muscle strength training. That's got really good evidence on working directly on high laryngeal movement and kind of UES opening and vocal cord closure. So that might be something that's helpful, especially if someone's got a good airway and you can cap their trachea to do it. Fees biofeedback. So I think fees biofeedback is really, really good, especially as we're saying, and we're hammering home, lots and lots of sensory impairments. And it's really hard, explaining to a patient, oh, well, there's something in your throat still. If they can't feel that, then it's then very hard for them to kind of respond. So actually fees biofeedback, if you can do that, scope them, show them what's there. And I would say even patients who are quite cognitively, not really cognitively impaired, but have some level of cognitive impairment can engage with this because it is so visual. And then also thinking about their cough and chest management, if there's anything you can do to optimize that, and of course their general kind of physical rehabilitation.
So in terms of how we then monitor weaning and the progress forward, it has to be quite systematic, and we'll need to make sure that we are formally monitoring that to keep evidencing the progress of these patients. So you might be looking at clinical assessments, things like their subglottic port volumes, how often you're having to suction them tracheally, chest infections, so you're thinking about how often are they happening, how many times within a set period of time. Are they potentially related to an aspiration risk, or are they something that is coming out of the blue because you've had other chest infections on the ward and it's that time of year and things? So you're looking for patterns within those chest infections. You'll be continuing dysphagia awareness and looking at FEES one-way valve protocols. That would be potentially looking at on your FEES, what's the swallow like without the one-way valve, but with the cuff up?
Yeah. What's
the swallow like with the cuff down? What's the swallow like with the cuff down and a one-way valve inserted? And how many times are you getting those swallows within a period of time of observation on your FEES? You're also going to be looking at things like your cough effectiveness, like we spoke about earlier, in terms of a voluntary versus an induced cough. How are you going to measure that? And it can be quite tricky in a neurodisability cohort, because a lot of them can't follow an instruction to be able to complete a voluntary cough. So you might be looking at, have you got the available equipment within your service to be able to look at something like an induced peak cough flow? And that would be that you need to trigger that cough somehow and then measure it. We understand that that's quite tricky. It's very tricky for us to do here as well. We don't have the availability of a lot of equipment to do that. And so you might have to be looking at a more subjective view of that cough and looking at, when does the cough occur? Are you having to do something to trigger the cough? Can the patient do it themselves without any kind of external trigger or voluntary command? Are they going to be safe enough to protect the airway on their own without any intervention? Some places may also be able to do something like, inspiratory pressure or mean expiratory pressure, and some articles will help, do have kind of guidance on what those ranges should be. But again, it's going to depend on what you've got available within your department to be able to monitor that. So big question, cap or not to cap? Probably comes up a lot in discussions. We know that we have discussions here with our medical team about whether it's needed, whether it's not needed, when would you use it, what's the benefit of doing it. There are a few things to consider when you're capping a tracheostomy, and this is getting towards kind of the end of your weaning process once you're happy that a lot of other things are managed. And it's helpful for you when you're trying to test a hypothesis about whether a patient has got a good, safe patent airway to be able to manage without their trachea, and whether they're going to be able to manage without the interventions that you would provide through a tracheostomy. But you're looking at things like the fit of the cap, and that depends on the type of cap that you provide to the patient. Some of them are designed for single lumen tubes only. And so if you're using your standard kind of vortexes and tracheo twists, they may not stay on so well, or they may not fit on properly in the first place. So you will need to just check that you get the right type. It is more occlusive than standard breathing. And so you've got to remember that there's obviously a tube within the airway, and they're trying to breathe around that tube, and you're capping it so that the air has to find a way past. If you've got quite a large tube and you're capping, that could be quite difficult and uncomfortable for the patient. So you might need to think about whether the tube size is right and whether you need to downsize. But you also might just think about using the cap for short durations only. We tend to talk around potentially using it for around 4 to 6 hours at a time, not doing it too long, because what benefit are we getting? Once we've had it on for 4 to 6 hours, we can tell whether there is an airway issue or not with it. And sometimes if you're leaving it on for longer periods of time, prolonged periods, then you can get problems with fatigue and then the impact of the work of breathing on other mechanisms. If you're starting to change the way that your breathing pattern is, you're going to impact your swallow. If your breathing pattern is getting more effortful and you're tired, you're going to have a reduced efficiency of your cough. So you're looking at how the patient's tolerating that valve. And then if you're trying to use it for longer, what's the benefits of using it for longer? We're also looking for things like stridor pattern. You're looking to see when you observe that, if you do observe it, and obviously we would hope that that doesn't happen. But if you're hearing the stridor on inspiration, there's probably more likely a glottis problem. If you're hearing it on expiration, it's probably more likely subglottic. In our neuro population, you are going to be thinking about the positional impact of using your red cap. And so if you have things like quite low-toned floppy airways, they may be fine in a sitting position, and so the red cap might be tolerated well during the day, but when you put someone back to bed, there may be more issues as you're lying them down into a supine position. And so what we often do, while we don't necessarily use them for long periods of time, we might try it in different positions, and we will potentially go in the morning during kind of, when the patient's before they're up, and try and put it on in a lying position and see whether there's any difference, and see whether we're hearing any difference to the breathing pattern or airflow. Tracheomalacia can be missed with a cap on, depending on the level of the tracheomalacia. I think Amy was just going to cut in there.
Yeah, I was going to say, in terms of, I think it comes down, again, kind of as we're going to get onto the clinical reasoning. So if you've seen a patient, you've scoped them and their airway looks good, then you might just want to finger occlude them very, very briefly, or cap them very briefly in different positions and then decannulate them. It's totally, again, there's no kind of hard and fast rule. And that's because you can miss other things. So actually, if someone's got tracheomalacia and their tube is stenting their airway, and they've got enough force that even when they're capped, they can breathe out around the tube, they will still look fine. And when you decannulate them, they still won't manage. So again, it's not it's not that, you've tolerated them, they've tolerated capping, they're definitely going to be 100% fine. It's all about thinking about clinical reasoning all of the time on your assessments and observations with patients.
So when it actually gets to the point of deciding around the decannulation itself, it has to be an MDT decision with discussion needed and clear documentation about how the process is going to go forward and how that decision's been made, that the patient is actually stable and ready for decannulation. There is questions around whether you should have direct airway visualization as you're completing that decannulation and just before the decannulation, to make sure that you're happy that the airway is patent and suitable for going forward with the decannulation. But you're also going to be making predictions based on your clinical knowledge. So everything we've talked about so far, looking at their dysphagia, their airway, their respiratory management, how stable they are. Have you been able to see them when they are well and unwell? What's going to happen if you take that tracheostomy out and they get a chest infection? Are they still going to be able to to manage their secretability in your patients. And so you want to know that no matter how they present, they are still going to be able to tolerate it. And also just thinking about the predicted trajectory of the patient. Are they going to be progressing further from where you are at the moment? Are they quite stable in their presentation, or is there something that could potentially cause them to deteriorate in the future? You might want to consider whether decannulation is right for that patient based on what's happening with them in the long term. You're looking at things like personalised goals as well, and looking at the risk benefit for that patient. When you're considering when you do this, timing and place of decannulation is key. You want to do it at an appropriate day on the ward when there's plenty of staff around who are going to be able to respond if there is a problem. So you don't want to be doing it on a Friday afternoon, no one else is in for the weekend. Potentially, depending on what's happening with the patient, you may also want to consider doing this within an ENT clinic so that you can have more support if you are concerned that there may be some sort of dynamic airway collapse that you want to test while you're withdrawing the tube, and then being able to look at the airway and what's happening as you remove that stenting kind of support from the tube itself.
And I think that's good, because sometimes we might write off a patient being decannulated because we have a concern, but actually then doing it in an ENT clinic where you've got that support. We've had quite a few successful outcomes doing that, whereas we might not have necessarily have done that on the ward because we might have felt like we didn't have the right ward support. So I think taking risk is really good, just making sure you have the right support around you.
It's is there going to be a recannulation plan? What's going to happen if they do fail? And obviously that's a huge discussion, and may need to be a best interest kind of discussion for the patient, depending on how severe their neurodisability is and whether they're able to engage in those conversations with you. It may be appropriate that they are recannulated in some situations. You may have, as a team, made that decision that it isn't appropriate. And within the long-term management that we'll be coming on to, we might consider some of those aspects where patients may not be in the right position to have a recannulation.
Okay, so a quick note on trachea and PDOC. As a PDOC specialist centre, we thought we ought to manage it, to mention it, sorry. So we know that people with lower GCS are more likely to have a trachea placed initially, but I think the jury is really out on the relationship between level of consciousness and decannulation success. So several articles talk about having a GCS of more than 8, but then some said GCS is not related to decannulation success. There was some evidence that subjects that improved their disorders of consciousness were then 11 times more likely to be decannulated than those that didn't. But then also there's lots of people in vegetative state who have been safely decannulated. So I think it's really about looking at what the clinical presentation is and all the things that we've talked about before. I think if someone says to you, they can't be decannulated because they're in PDOC, then that's, we would say that's not right. It's about clinical presentation and need, and as much as you can, establishing what is in that person's best interest. There are, however, some more specific challenges that come up in tracheostomy management with that PDOC population. So particularly around oral care and bite reflexes. We know that's much more common in a PDOC population than in a normal neurological or a higher level neurological population, and this kind of poor postural control and awareness. So these are risk factors that we see more commonly in PDOC patients than necessarily in the rest of our neuro population. So we need to be thinking about those and considering those particularly. I think we also need to think about, with tracheostomy weaning, we know that does open up communication, and if swallow improves, kind of oral intake potentially, and that can have value when it's done in the right way in relation to patients that are emerging from PDOC. So actually we know that kind of speaking is a very automatic thing. So actually if we've got someone that's very low level and we suddenly can get them to the point of tolerating a valve, that might be the easiest way for them to demonstrate some communication behaviours to us. And the same with oral intake as well. And ultimately, coughing and swallowing are reflexes. We've talked about how these things can be kind of dampened down and variable, but we've had loads of patients that are vegetative state, very low level, that we have successfully decannulated, and some of them have been really, really straightforward, and some of them aren't. So I think there's no hard and fast rules, but again, really comes back to clinical reasoning. Okay, so a little bit now about when weaning doesn't work, and it's hard to kind of give really specific examples over that, but I suppose these are the types of points that we thought were relevant to kind of go to when you're starting to troubleshoot. And you can see lots of kind of nice, weird and wonderful pictures here on the screen. But coming back to your anatomy and physiology, it sounds really obvious, but the anatomy and physiology of the airway and the respiratory system and swallowing is quite complex. So I think having a sound understanding of that and going back over what you might feel like are the basics can be really helpful when we're thinking about sensory and motor impairments and poor tolerance of weaning. Review them in different conditions. So think about what your hypothesis is. So, you know, when you're going in, make sure that if you're going into ENT, for example, that you have a question. So start with the question and hypothesis. Even if it's wrong, it doesn't matter, but at least you're starting with something rather than just, oh, this weaning's not working, I don't know why. Review your persons are in different conditions. So try them, you know, with different tubes potentially, or cuff up, cuff down with the valve on, look at what the patterns that you are seeing. Use the right type of assessment. So again, sending someone to ENT when you've got maybe some stridor at the level you think, well, there's something subglottic going on. Not all ENT will scope below the level of the cord. So if you do an FNE, you're probably not going to see what the problem is. So thinking about, okay, where do I need to scope? Is it to the larynx? Is it down the trachea? Is the tube going to be stenting the problem back? Do I need to scope them without the tube in? Or is it subglottic? And do we actually need a CT neck to see what's going on here? So think about the assessments that you're using, and you can be guided, have discussions with the medics and ENT about this. As I said, have a hypothesis and explore what's happening, and make sure you get the right people for the right job. It's really, really important. And you'll see the picture here on the bottom left. This was a chap that was really struggling, but actually once you look into his airway, you can see it's just really poor secretion management that was just an absolute problem. And, you know, he was quite sensate, so was really, really uncomfortable and struggling. And then you get weird and wonderfuls. This is somebody that we scoped last week with a very interesting epiglottis. We're still pending what to do on that one. So yeah, you do get kind of, you know, interesting and weird and wonderful things. And not everybody can be weaned. But I think what we're saying is explore a range of things and keep asking questions. That's really, really important to get the best outcome for the patient, but also for your learning and development. Okay, so I'm just going to talk through really briefly, in the interest of time, 2 situations where weaning didn't work for us and kind of what went on there. So the first patient, Miss S, was somebody that was in PDOC. She'd previously been scoped and it was deemed that her airway was fine. She was on the level 1 unit, and then I picked her up when she went over onto our long-term care. The weaning was stopped because every time the cuff came down, there was questions about, oh, she's not managing. So she was getting really distressed. She was having a bit of a weird cough, and they were saying, oh, I think it's secretion issues. But actually her secretion scores weren't that high. She was getting quite a bit pulmonary, but she wasn't getting loads of her subglottic port. So we're thinking, okay, what's going on here? So I didn't really think the secretion issues necessarily matched the really extreme response we were getting when the cuff came down. We thought maybe it's just hypersensitivity. So we need to take the cuff down more, restore the airflow, start to normalize things. But there was this really weird kind of wheeze sound. We were getting some thicker secretions in the chest. There was a background of asthma. So then there's like, okay, is this an asthma exacerbation that we're just not kind of managing? Obviously the patients in PDOC, they were vegetative state, so they weren't able to kind of self-report anything to us. Then we saw this wheeze and this kind of bronchospasmy picture even after suctioning. So I'm like, this is, you know, this is a bit strange. So we'd optimized her saliva management, and I wasn't certain, I didn't feel confident that that was really anything to do with it. I thought that was a bit of a red herring. So we decided to scope her. So we looked in the upper airway and the trachea with her cuff up, absolutely no issue. We then took her cuff down when all this kind of coughing and things started to happen and this real distress, looked in her upper airway, looked good. She was obviously, you know, really going for it. She seemed a bit hypersensitive, but it wasn't so significant that it would be causing that much of a problem. But then actually, when we went into her trachea, we could see distal to the tube, there was loads of tracheomalacia, and it was, you know, kind of real tracheomalacia. So actually the lateral tracheal walls were just dropping in on the cuff deflation. So although we decided and we knew that we couldn't take that trach out, it would be way too risky because we don't want someone to lose their airway, it did give us really helpful information. And actually we knew that then it was an airway, it was a tracheal it was tracheomalacia, it was a tracheal issue rather than being an asthma issue and then starting her on medication from that. And we know that lots of upper respiratory tract problems also get masked as asthma, as an aside, although this was obviously a lower issue. And it was good because it meant we could stop playing around with the secretion management that we kind of felt she didn't really need. And they have lots of kind of negative side effects. So we could get her off that, and we could just kind of deal with the fact, okay, this is severe tracheomalacia, gives us information about when we're changing her tube and who should be changing her tube and when she would be doing it. And it also makes us think ahead, okay, if we're starting to notice other problems, is that tracheomalacia extending? Do we need to be thinking about an extended length tube, etc.? So it gave us a really good answer. The second patient I'll touch on very quickly was somebody else that had a neuro-rehabilitation period. She had a really good ability to engage, had a really good cognition, was eating and drinking, but swallow was not kind of 100%, but was mobile. And she ended up being discharged to a neurospecialist nursing home because she needed the tracheostomy, and she wasn't able to go home and sufficiently care for it, or her family care for it at home. And she was very dysphonic, and she was found to have a unilateral vocal cord palsy in midline and some arytenoid collapse with lots of edema and erythema in the larynx. And her airway wasn't patent enough for her to be decannulated, essentially. She wasn't tolerating capping, and at the time of her inpatient stay, they deemed her not suitable for decannulation. I'm not entirely sure why, but that's kind of what was handed over. So when she came out into the community, we got her managing a smaller cuffless trachea. We had a look at, okay, what else is going on in the airway? So things, as we said, we know things are very red and swollen. Okay, we're thinking reflux. So we did a lot of reflux work with her, and she was reporting these symptoms as well to try and kind of optimize her larynx as much as possible. We capped her. She still wasn't tolerating, but she was a bit kind of, it was a bit more kind of, hit and miss. Actually, maybe things are changing. And we know that unilateral cord palsies do change, can change over time. So we had her seen again by ENT, and actually she was deemed suitable for surgery. So what they did is they resect part of the posterior part of the cord, and that meant that then obviously she had a patent enough airway. Now, prior to that, she needed a baseline assessment, a video fluoroscopy to check her swallowing was okay, because obviously there's always an interplay between laryngeal surgery and the impact that might have on swallowing. But she was also very anxious, and then she started developing kind of hyperfunctional voice use. So we did work on deconstriction work, and kind of healthy larynx and voice work, voice hygiene. So this was a combination of kind of spontaneous recovery over time. Her vocal cord palsy improved, optimizing her laryngeal health, and also some behavioral modifications in terms of deconstriction work and anxiety work. And then she was really successfully decannulated, and she managed to be discharged home because she didn't need a trachea anymore. So that was a really good outcome kind of further down the track. So a word quickly just on surgical considerations. So we might consider surgery for our patients because to support airway patency, to kind of get them to decannulation. And always, if someone's going to go and have surgery on their airway, they need to have a baseline dysphagia assessment, preferably a video fluoroscopy, to ascertain the risk of the surgical intervention. So where ENT going to take, they want to take a bit of the arytenoid, they want to take a bit of the cords. But we know when we swallow, we get this nice kind of arytenoid bunching up to the underside of the epiglottis that helps us close our airway. So if we're taking bits of this, how's that going to impact airway safety? And this definitely needs to be an MDT decision. So as I said, always a trade-off between voice ability, swallow, and airway. And we have to think about what is the biggest priority for the patient. We had a patient recently who had that posterior glottic scarring from intubation trauma. That meant the cords were fixed together. He was taken to theatre, and what they do is they first mobilise the joint to work out kind of what exactly is going on. They said, yeah, it's post-glottic scarring, but it's big. We need to give it a big snip. Now, this patient was managing a cuffless tube, but actually when we feesed him, he was kind of intermittently aspirating, but he was managing. And again, this patient was a patient in PDOC. So actually, he was stable, he was doing fine with the cuffless tube. So then there's a conversation about, okay, well, they could do this surgery, they could take part of the cord, they could improve his airway, and they might decannulate him, but what's the knock-on impact of that onto his swallowing? And we know he had some dysphagia. As I said, he was intermittently aspirating, but he was staying well. The surgery would be likely to be successful for airway, but it could knock off his swallow. And then we're thinking about, okay, more aspiration risk. He's not able to engage in any dysphagia therapy, his PDOC. He might start then needing to use loads of chest treatment, which we know can be really invasive and distressing, even if you're in a low level of awareness. And he's not able to self-report to us what's going on. So in the end, in his best interest, we decided not for surgery, keep the tube in and keep as we are. But again, that problem-solving process is really helpful. And it's also very helpful when explaining it to family as well. Okay, so thinking about what makes a good outcome, obviously a good outcome for everybody is different. And that's kind of the point here. So, you know, voice, swallow, airway, all related. You treat one and you knock off the other, but what's important to that person? Quality of life is different for everybody, but we just need to make sure that we're following the principles of the Mental Capacity Act and best interests to ensure that we are kind of going through the right processes to get the right outcome. So for some people, it might just be, I know I've got tracheotomies here, it might be just getting the trachea. That's what they want, regardless of how unwell they get, regardless if it shortens their life. They hate the trachea, they're trying to pull it out all the time. You know, getting rid of the trachea is the aim. And you know, we will do that. We will take tracheostomies out at risk if it's in the best interest of that person. There's obviously, I think it's fair to say there's a level of risk. We would never take a tracheostomy out of someone that's going to go kind of into immediate respiratory distress, but we need to think about what's right for that person. And also I think the care interventions that are needed around tracheostomy, sometimes that can be quite distressing for patients and it's something that they don't enjoy. If you can make a decision with the patient, great. If you're making decisions in best interest, I think we would say that that needs to be, of course, a team approach, but I think observation of the patient with their trachea and their interaction with their trachea is really, really important to look for these behaviours. And these aren't conversations, I think from our experience, we would say these are not necessarily conversations that you could just have on the ward. They require a kind of formal best interest in getting all the information together because it's quite a lot to consider.
So when we start talking about patients who've got long-term tracheostomies, how do we know what a long-term tracheostomy is? Because there's no really clear definition of that. And nothing in the literature says this many months or however long this patient's had it. So we're probably looking at those who've maybe tried a full weaning trial but haven't been able to decannulate for a reason. There's been some sort of attempt that's failed. So these long-term tracheostomies are now going to be living with this tube in and you know, for as long as they are alive now. You're looking at the fact that with a long-term tracheostomy, you have got a foreign body in their neck, and there will be cumulative issues from this. And so all the things that we said about earlier when we were talking about why we want to try and get rid of the trachea, we've got to now try and manage in a long-term patient. I think as Amy's kind of shown with those case studies, that a careful slow wean is possible over a longer period of time, but we have to kind of keep in mind all of the things that we've talked about in terms of best interest for the patient and what the patient wants. And then try and manage where we can, comfort and care for the patient, make the decisions around whether we want to go back and retry a wean if we see changes. If we don't, how are we going to manage the patient in terms of keeping them safe and trying to prevent those secondary complications? So one of the things that we often do when we have patients who've got a long-term tracheostomy is look at what type is right for that patient. We might also be doing this with some of the weaning patients if we're looking at how do we make sure that the tube is not too big and occluding their airway. But when we're looking at them for a long-term patient, we're actually thinking, do we need to improve the seal of that tube? So if someone has a tube that's not sitting well in their airway, and you can see in the picture on the bottom left-hand corner of the screen that you can have angled tubes that go almost straight down and curved tubes which sit slightly less of an angle down into the airway. They will rest in different positions in different people's anatomies. It also will mean that that cuff and that seal is maybe not so good on certain types of tubes in certain people's anatomies. And so we'll be looking at here whether we need to change from one tube to another tube to try and improve that. If we've got someone who's having lots of multiple repeat chest infections because they're aspirating, we've tried to manage their saliva, we're clearing their chest effectively, but we're still getting problems, it may just be that that seal is not good enough at the moment. Looking at a different tube can sometimes help that. Sometimes upsizing just slightly can help. We do sometimes see a difference with just even a slight change in the type of tube that's in there. There will also be changes over time with a patient. If they're having a tracheostomy long term, they're going to potentially change from a tonal point of view. Their neurological condition can decline. That may impact things that they were managing before. So if someone was potentially using a cuffless tube and was managing to swallow, manage their saliva, but actually their neurological conditions declined and they're no longer doing that, we might have to consider whether we move from a cuffless tube back to a cuffed tube, just to help keep them safe if that is what is felt to be in their best interests. Tubes may also change just to mitigate airway issues. And so if we're seeing things like a development of a tracheomalacia, we might need to put a longer tube in just to stent open that airway a bit more. But it might also be that something like granulomas develop within the airway themselves, and the longer tube can bypass that granuloma to give it time to heal. The other thing just to be aware of is just that if you're looking at your tubes, a standard Portex 7 is not necessarily going to be the same size, well, it isn't going to be the same size as a standard Tracheotwist 7. And so when you're looking at what fits best for your patient, you might need to move between different manufacturers to make sure you get the best fit. And the table in the corner just shows a very small summary of a few of the common tubes that we see, but we're very lucky here, and we do appreciate that we are lucky here that we can get hold of a variety of different tubes. We do understand in acute settings that can be much more difficult because often a hospital has a contract with a certain type of trachea supplier, or it could be led much more by a consultant. But if you do feel very strongly that a different type of tube might actually help your patient, then it is worth trying to have those discussions around whether something different will suit the patient more. And thinking about the bigger picture long term, what are we trying to consider in terms of this trachea? We want to make sure that we're keeping medical stability for the patient and not necessarily causing lots of invasive chest management unless we really have to. So we do want to kind of make sure that patients are as stable as possible, that their care needs are met, and the correct type of care is provided for them. With a long-term trachea, there may be concerns that community access could be limited, but as long as we're putting in place the right kind of risk assessments for that patient, there's no reason why those patients can't get out and access the community. They just need the right support to do it. Within that, you're looking at their quality of life. No one wants to sit in a hospital bed for the rest of their life. You know, we want to try and make sure these people can get back to doing the things that they enjoy as much as possible. Tracheostomy may also just impact the discharge destination. So when you're thinking about discharging your patients from your acute or rehab setting, you're obviously looking at, is home a viable option in terms of the support and staff training that they might need for that, or is it that they need a care home to be able to manage the care? And you're looking at how much intervention does that tracheostomy need and what is available in the area for that patient to be able to manage that. Patients are also having to learn to adapt to the aesthetics of having a tube. And that can be quite difficult for some of them to come to terms with. It's very different having that visible kind of sign of having tracheostomy. And there could be implications around behaviour, which is something we were kind of alluding to earlier, that there are patients, particularly in the neurodisability population, who are going to have behavioural changes and maybe don't understand what that tube's for, and will be trying to reach at it, pull at it. And so you're then thinking around how can you manage that to the best of your abilities without trying to put too many restrictions in place. But in terms of whether that, you know, your long-term management and what you decide to do if a patient it does pull on that tube, if you know what their airway is like underneath that, you can help risk assess then whether if they pull that tube out, is it something that needs to go back in, or is it something that you could potentially leave out and assess that patient without the tube in. So it's good to have a really clear history of your patient, what's happened to them prior to you getting them as a long-term patient. You need to know whether there is any potential that they could manage without that trachea. Costs and funding obviously do come into this. We know that it's not fair, and there will be differences between different areas of the country. So in the RHN, in terms of long-term follow-up, all individuals with a long-term tracheostomy who are in the nursing home environment are reviewed at least every 6 months in the MDT tracheostomy clinic. And that's managed by the clinical specialist respiratory nurse, a consultant nurse in ventilation and tracheostomy management, a physiotherapist, and a speech and language therapist, along with the ward team. Within that, we'll review their tracheostomy care plan, looking at what's their chest management like, what's their humidification plan, what type of tubes they have in, is that still suitable, is it stopping chest infections, or are we seeing a change in their pattern of chest frequency and chest infection frequency? And then we might look at what we can put in as a plan to try and help mitigate some of those problems. We'll look at any previous weaning attempts within that review, and if there's been a change in the presentation of that person, to see whether it's worth revisiting a weaning attempt. But we'll also be taking into account what that person's treatment escalation plan and advanced care plan says, and also whether they're having any CAN-H discussions as well, which is obviously quite a big thing within the PDOC population. And we don't want to start something if there is a discussion around potentially CANH being withdrawn. The tracheostomy clinic can also refer back into other services if an identified need is found. So saliva clinic, ENT, or back to the therapist on the ward to try and manage.
And this is some of the actions. We just had a look back at our trachea clinics documentation, and these are some of the kind of outcomes that we've had, which I think really we're doing to illustrate that actually, you know, trachea weaning shouldn't just happen in the acute and the kind of acute rehab or level 1 settings. We need to be thinking about it broader than that. It's something that really does require this ongoing review. So we've got the simple things, you know, like changing the care routine and optimizing that, thinking about the tube type, as Linda said, thinking about the saliva and their secretion management, which may be up and down dependent on kind of their medical status, or just, you know, as time goes on, people change, managing complications, but also things like, you know, actually finding out what does the patient want. Sometimes our patients go into long-term care beds and actually they do change over time, and then they can be engaged in goal setting and discussing what's important to them, or, you know, starting weaning and communicating and looking at kind of oral intake and dysphagia management as well. So we've had some really nice outcomes, which, as I said, it kind of just illustrates that actually this need is ongoing. And I think we discharge a lot of people into community and say, oh, you know, they've gone to a trachea bed. But actually, we need to be clear as therapists referring into community services that there is a difference between a community service that can care for a trachea, i.e. suction it and make sure everything's clean and tidy, versus a community setting that can wean a trachea. And lots of these patients in this neurodisability cohort do deserve and require reviews for their weaning ability and all the other things that go with it.
So in terms of discharge with a trachea, you're just thinking about how's that person living with a tracheostomy, and not every patient is going to go out into the community, which we understand. Care home discharge is probably much more easy, but if you're thinking about discharging out into the community, it's just making sure that that patient has a good individual risk assessment and care plan, including things like frequency of suctioning, how often should the inner cannula be changed, what's their chest clearance routine, what humidification are they using. You want to be aware of who's going to be monitoring that patient and what's the emergency management plan in the community. Do the carers or the family looking after that patient know what to do in an emergency? And who's going to be providing the care? Who's going to be keeping the competencies up of the person looking after that tracheostomy? Big thing, who's going to be supplying ongoing consumables, probably the bane of our life when we do discharges into the community. It's never easy. It varies depending on which area the person's discharging into. But it's worth getting things like that started early just to make sure that things are in place. And the other thing to just consider is who's going to be completing that 4-weekly tube change, which is the recommended changing frequency of your tracheostomy tube. You can also support patients, just giving them links into some of the support networks that around. The NTSP do have some guidance on support networks and peer befriending. They have a list of different websites and communities that would be able to support patients with a tracheostomy or their families.
Okay, so we've got through it, some final messages. So I suppose, hopefully we've given you a bit of an overview today and things to consider at kind of this introductory level to managing tracheas in this complex neuro cohort. And it's not that straightforward. I think, as I've said before, we sometimes maybe oversimplify it. We don't want to make it really, really, really complex, but I think there's lots to think about, and we need to make sure, and our patients deserve us to be doing that for them. Explore your causal factors. So have a think about, you know, what is the reason that this person has this tracheostomy, and what is the reason for their ongoing needs specifically, and what can we do? We definitely need a whole MDT approach. None of us can work kind of alone on this. We need to be having conversations. We need to be discussing it. Sometimes we even kind of sit down and just scribble all over a bit of paper everything that's going on at once and work out, okay, what do we need to sort out first, blah, blah, blah. And then we can take that to the patient or the family and say, okay, this is what we're thinking. What do you think would be important to them? So really kind of think about it all. Start with a hypothesis and test. Timing is really crucial. So we've illustrated, you know, that actually sometimes it's appropriate to start weaning really early. Sometimes we get outcomes and it's much further down the track. And that's why this review and retrialing things is really important. Not all success looks the same. So for some people, it might be more important for them to be able to be decannulated and go to a nursing home or a care facility or home, rather than keep their chest healthier for longer. Okay, everybody's view of what's successful looks differently, so we need to be open to that. And of course, this long-term follow-up is essential. And we know that it's not widely available. We're really lucky here because we have involvement with all of our long-term trachea patients. They're seen every 6 months, which I think is great. But we know that we're kind of that's not common. Yeah. So we understand the challenges that the community teams face. Okay. I think that's it from us. We're right on time. I don't know if we have any time really for any questions. I don't think we do. I'm very sorry about that. But what we'll do is we'll collate some questions from the chat. I think, I'm not sure, are there questions on the chat? Yeah, great. So we'll collate some of them and we'll try and answer that. I'm not sure how we'll do that yet, whether we provide responses written or we try and do a bit more of a discussion. But thank you very much for joining us. And hopefully you've all enjoyed it. And yes, please do get in touch if there's anything. We're a bit like, we both love it. So yeah, please do get in touch if there's anything kind of that you want to discuss or any interesting projects or anything going on. It'd be great to hear from you all. Okay, take care. Bye.
Thank you.